Welcome to Walk, Don't Run to the Doctor, where we are helping people avoid the burdens of preventable disease. By using evidence-based lifestyle tools to unlock each person's intrinsic healing ability, we're going to be supporting healthy families, healthy communities, and healthy individuals. Making your own food and moving every day vigorously can help you gain freedom from health debt. We can prove it. So today we're going to be talking about type 2 diabetes, and thank you for joining us. Think about this in terms of people you know. It might be you, it might be somebody else, it might be a loved one, and see if what we're talking about can help somebody with diabetes not have diabetes, somebody with pre-diabetes not get diabetes, and help everybody in your circle be healthier. I'm Miles Hassell, MD. You're listening to Walk, Don't Run to the Doctor, and please join me in welcoming Fawn Wolf. Dr. Wolf is an endocrinologist who will be speaking at our upcoming Type 2 Diabetes Reversal and Lifestyle Medicine Conference in Portland, Oregon in late April of 2025. Dr. Wolf grew up in Michigan. She earned her bachelor's degree in molecular biology from the University of Michigan. Are we all correct so far?
That's right on.
She went to Medical College of Ohio for medical school and then moved to Portland, Oregon for her internal medicine residency. And she was chief resident in Legacy Health Systems. And she's been in Portland for a couple of decades now. So tell us a little bit about how you sort of approach your practice, your relationships with your patients and so on.
Well, I was one of those funny kids. I kind of always knew what I wanted to be when I grew up. I always knew I wanted to be a doctor. I thought it was fun to go to the doctor and meet with them and have those conversations. And then my mom had type 1 diabetes. So she was diagnosed as a teenager. So my entire life, I knew her as having type 1 diabetes. And so I really got to see what that was like from a personal standpoint. It has a huge impact on somebody's life. Really, I got to see how the different relationships she would have with various doctors impacted her. So she would come home from some visits feeling, boosted up and motivated. And then she'd come home from other specialists and feel really dejected and really upset by how the conversation had gone. I remember a number of times where she would tell them things, even something like my insulin needs are higher the week of my menstrual cycle. And they would say, well, that's ridiculous. That doesn't make any sense, which we now know is true. And the details don't matter so much, but it was really that take home point of, what you're telling me about your experience with your body and your health is wrong. I think I take that with me. I think I know that we never know everything. We're always going to learn more things. And you have to believe what the patient is telling you about what their experience is.
Yeah. That's actually interesting. A bigger issue of the whole arrogance of medicine where we pretend to know things we don't know.
Sure.
And you hear, and I think I've been as guilty as anybody else of thinking I knew something because 30 years ago I heard a lecture on it.
Right.
And so I'm quoting something that is just wrong that I haven't ever bothered to double check on. And our patients serve as a potential double check for us.
Yeah.
Raising a question and hopefully making us say to ourselves, is what I'm thinking correct?
And teaching too. I teach a lot of the residents and they'll ask me a question. I think, I better look that up to make sure I'm still giving them correct information and not just what I learned.
Yeah, I get to think out that and talking to the residents, and then I'm talking about something that I think I know something about, and then I find out that the resident I'm talking to has a PhD in that area and published a paper on it, and he says I'm wrong. Yeah. Well, he's probably right.
He's probably
right. So good. And those were in the days, of course, your mother had to suffer through the days when it was much harder to check your blood sugars.
Oh, sure.
Your insulins weren't as stable.
No.
All of that kind of thing. It was a much tougher disease back then.
Yeah, we didn't have nearly the tools that we have today to help with the macromanagement.
So her mother had type 1 diabetes. We're actually mostly going to be talking about type 2 diabetes because we're having a whole conference on this subject. And there are a little bit of overlap between the two, but they're really entirely separate diseases. Am I correct in saying?
Oh, yeah. Completely overbeast.
Yeah. So the only thing they have really in common in a sense is they deal with blood sugar and they have the word diabetes in their name. So this is going to be about type 2 diabetes. And Fawn, tell us a little bit about how you see the harms of type 2 diabetes.
Well, it's at every level. So, as we know, type 2 diabetes is so common in our country, unfortunately. And I think about multiple levels. So at the very base level, when you have high blood sugars, you don't feel well. And you might not recognize it in the moment because that might have become your norm. But high blood sugars can impact energy, motivation, mental acuity. Often people talk about brain fog and just feeling a little bit fuzzy. So you don't feel good when sugars are high. You also don't feel well when sugars are low, which can happen in result to the medications that we use sometimes. Next level up, the high blood sugars over time are bad for the body. It's not how our bodies evolved to be. Our bodies evolved to have, more lower blood sugars. And so having high blood sugars over time, as you know, is bad for pretty much every organ in the body. We think about the organs that are dependent on the small blood vessels, so the feet, the kidneys, the eyes. And then we also think about the organs that are dependent on the big blood vessels, like the heart and the brain. In the last, decade or two, we've become more aware of how high blood sugars are bad for the liver and is taken over as the number one cause of liver failure in the country. Also bad for the bones. So bad just from head to toe. Next level up, we think from a population standpoint, it's not good to have such a large portion of our population be unwell and be unhealthy. So it contributes directly and indirectly to loss in production and just general unwell.
An enormous cost.
At enormous cost, yes.
Yeah. When you think about that, what kind of approaches do we have? What are our options in treating this? Because I think we'd both agree it's increasing in incidence fairly strongly. Yeah.
Well, we have a lot of options. The option a fair number of people choose is to just ignore it, pretend it doesn't happen, pretend it's not happening. I think it's easy, especially, like I said, sometimes you might not even realize how the high blood sugars are affecting you. You might feel normal. And so it's one of those conditions where it does require some work on the faith that that's going to prevent bad health outcomes for you down the road. So it does take a little bit of effort sometimes to treat something that's not immediately or obviously symptomatic for you. It's different than somebody gets a cancer diagnosis. It's kind of all hands on deck. Let's do everything we can. Sometimes diabetes and other chronic conditions can be a bit more silent, and it again takes some effort to think about what your health is going to look like down the road if you don't do anything about it. So ignoring it is something that happens. Active lifestyle changes is, of course, something that we'll be talking quite a bit about in terms of what we choose to eat, how much we choose to eat, how we choose to move our bodies. And then, of course, we have pharmacotherapy, so non-insulin therapies and insulin therapies.
And then, of course, we have all the therapies for all the complications.
Sure.
And that's when we really get into big money.
Yeah.
And big misery. I mean, dialysis.
Yeah.
I think it's overtaken alcohol for liver failure. Am I right?
Mm-hmm.
It's a major contributor to stroke.
Either men or women, one or the other. It's yeah.
And if you go down to our cardiac care units or ICUs, diabetes, patients with diabetes and some complication of it are a prominent player, frequent flyers in that population. And that means not just the cost of society, which is not insignificant, but far more important, the misery to the individual and the individual's family. It really takes over people's lives. Yeah. So at the conference, we're going to be talking about reversing or diabetes remission or reversal, however you want to express it. How real is that in your view?
Yeah, well, I have a short answer and a long answer. So the short answer is it is real. It's absolutely possible. And it may not be possible for every single person at every single time point in their life.
I know so like the direct study, they got about a 70% overall reversal. So when we talk about reversing or remission of type 2 diabetes, Fawn, how do you define that?
Yeah, so that would be a period of time where your blood sugars are in the normal range without the use of prescription medications.
That seems pretty straightforward. You're saying that type 2 diabetes remission or reversal is almost certainly possible in a high proportion of people.
In a high proportion.
Yeah. So just briefly, what our conference will be talking about is the value of remission in terms of quality of life, cost of all the medical care, and avoiding of complications. And we did an audit on our patients once, and we had actually a 70% reversal rate. But what was interesting to us is that the 30%, when we looked carefully at those cases, none of them had tried very hard.
Yeah.
So we're pretty sure that we can do better than 70%, but we don't know how much better because it is a ton of work. I don't think we should underrate the work involved in.
It is a lot of work. I would also say that, you can have this period of normal blood sugars without medications, but that doesn't just mean then you can stop trying. You've gotten rid of the disease. You're going to have to keep fighting for it, unfortunately. It's like the underlying risk factors that got you there are not going to go away.
Yeah. So your genetics are the same.
Right.
Your metabolism is similar, although we can affect that somewhat. But it's just like you can start drinking again if you're an alcoholic, you can turn into a type 2 diabetic again anytime you want. And that's why there's actually an argument over whether we should use the word reversal or remission.
Right.
I sort of see it as a semantic issue. Some people don't. But Fawn's point is really important that you have to stay at it. But as I say to people, only for the rest of your life. That's it. So, Fawn, what would you see as the basic elements of a type 2 diabetes reversal or remission program?
Well, we think about food, we think about moving our bodies. I think sleep is huge as well. I think that's underrated. So we can dive into those individual areas a bit more if you'd like. Yeah.
Waistline?
Waistline, for sure, is a highly correlative.
Yeah. Okay. Well, let's go back to that in a second after you tell me how you're going to motivate anybody to do this.
This takes time, and it takes sitting down with people and talking with them and knowing them. And that kind of gets back to my role as an endocrinologist. One of the things I loved and really value is those long-term relationships, because you get to know people. But sitting there talking with patients, hearing what's happening for them in the moment, I ask them, what's physically bothering them, what stresses do they have right now. When we think about trying to motivate people, I try to ask, well, where do you want to be in 10 to 15 years? Or if they're younger, where do you want to be in your 60s, 70s, 80s? Kind of envisioning that. Do you want to be still very physically active and engaged and traveling and enjoying time with your family? And a lot of patients do have this deep sense that, I don't want to be one of those patients who's on 25 medications. And so I think sometimes we can help, pull that motivation. That can be very helpful. We talk about family members. Do they want to be still enjoying time with their spouses, their kids, their grandkids, and act in a more active role or a more passive role? So we talk about, how are they feeling? Do they want to be relatively comfortable moving their body through space? Do they want to try to avoid a state where they're immobilized or in pain and can't do things because of the pain that they feel? So I spend a lot. I definitely bring that up. We think about, okay, where do we want ourselves to be later on in life, and what do we need to do to get there? And that's far more motivating, I found, for people than to say, okay, here's your A1C target, and we need to reach this A1C target, because that's not tangible enough.
Mm-hmm. No, I completely agree. What kind of elderly person do you want to be is really valuable. Do you want to be somebody who's just going to doctors, taking lots of medicines, when maybe they don't need to have the disease?
Sure.
Even if they can just largely reverse it, they're still way ahead.
Yeah.
Just touch briefly on what you're thinking about for food.
I think of a hierarchy here. I think, whole foods approach is best. I don't push any one particular diet over another. I think a whole foods approach is best. The more meals that can make them home, the better. Anything you get out is going to have more sugar, fat, and salt in it. What else?
Do you emphasize refined carbohydrates particularly?
Oh, yeah. Yeah, especially for this, specifically for a population with diabetes. We'll talk about being able to identify what has refined carbohydrates, trying to limit or eliminate those. We think about portions. We think about mindful eating. If this is within reach for a patient, some form of food tracking can be helpful. I've found that that's not always within reach for every patient. I think for some patients, especially those, it seems, who have earlier trauma in their life, any history of eating disordered behavior, that can be very difficult and often triggering and difficult. But if they're able to track food intake and use the information in a healthy manner, I find that's very useful.
Yeah, no, that sounds good. And activity? What do you do with activity?
Yeah, well, I start with just seeing where people are at right now. What's a typical day look like for you? Is your job active? Is it sedentary? Are you going on walks? Are you doing any focused exercise? And I wouldn't say that more is always better, because we do get to a point where more probably isn't better. But
not too many of us reach that.
Not too many reach it, yeah. But for the first 80% or so, more is better. So both in terms of intensity and duration.
Yeah, I've always realized I'm a bit of a slug, and so I wouldn't have to worry about over marathoning, because you a marathon, right?
I do. I'm in the overexercise crowd.
Right. So let's see. We talked about what you eat. We've talked about physical activity. Tell me how you address waistlines and how important you think that is.
Yeah, I have to admit, I know you do this. We don't routinely measure waistlines in my practice. I think we probably should. It definitely comes up in conversation. Patients will mention, well, I've made these changes and I'm feeling better, but the weight on the scale hasn't changed. And then I always ask, well, is your waistline smaller? They say, yes, I'm down a pant size or two. So that's clearly valuable for metabolic health.
But I think that the greatest predictor of who's going to be successful in reversing diabetes was whether they lost weight or not. Because remember, most of the time we're dealing with a overweight population. Not everybody with type 2 diabetes is overweight, just in case you think I'm painting with too broad of a brush, but most are. And so the idea of looking for 10% or 15% of your body weight reduction is strongly related to success, I think. Or is there more that you'd like to talk about for reversal? You mentioned sleep earlier.
Yeah, sleep. I love to sleep, but I think sleep is overlooked. So, from the endocrinology, the hormone standpoint, when you're not sleeping well, your circadian rhythms are off, your circadian rhythm with cortisol secretion is off. And all of that leads to increased stress within the body, increased insulin resistance, a harder time getting your blood sugars and your weight down. So I ask people about sleep. Ideally, you want to be going to bed at about the same time every night, within an hour or so. Ideally, waking up at about the same time within an hour, even on your weekends. Getting adequate sleep for you, that can vary person to person. So it doesn't have to be 8 hours for every single person. Some people get by really well on 7 hours. 6.5 maybe. Some people need 8 or 9. So knowing what your body needs, where you feel good, and then really making that a priority.
And do you address sleep apnea very aggressively in that regard?
Well, I refer a lot of people for sleep studies. Yeah. I pick up on it commonly.
And if we can not just treat sleep apnea, but also simply the weight loss.
Oh, sure.
Sleep apnea a great deal too. So yeah, okay. Anything else you'd like to add in terms of reversal? So you mentioned diet, activity, physical activity, weight loss, sleep. Anything else that jump out at you?
Those are the big ones.
I guess, and I think in terms of looking to the future, I think you've also alluded to the whole concept of purpose,
Sure.
which really relates to motivation as well. So I like that. How do you track this? So you're helping somebody reverse their diabetes. How do you track them?
Well, as we mentioned already, the A1C is a commonly used tool, and I think it's valid. So A1C tells us the average blood sugar over the past 3 months. So it's not just last night. Sometimes we'll get a high A1C back and somebody will say, well, I went out for dinner last night. Like, well, that's not the explanation. So it tells us over 3 months, with the more recent time is more heavily weighted. And so we have A1C's goals that we're looking for that correlate very well with complication risk. And so we do track A1Cs. We're doing less finger stick blood sugar monitoring than we used to. It can be useful, but it's such a single snapshot in time of where your sugar is right then. It's just not a whole lot of information. So we are using far more continuous glucose sensors. We have been for a long time in patients with type 1 diabetes, but type 2 diabetes and even prediabetes, they can be really valuable tools for seeing how my body responds to this meal versus that meal, how my body responds when I'm in pain and or under stress, how my body responds to not getting a good night's sleep. So I think those can be really invaluable tools. I would also like to say that you don't need to wear a sensor 100% of the time. So I'll have some patients who, especially if their insurance doesn't pay for it, they're paying out of pocket. That might be in the range of $60 for a 2-week sensor, I think, for a cash price. So they might wear it for just the 2 weeks before their visit with me. And that kind of helps them and me and I zero in on any trends that they're having.
How do you deal with the surprise people get when they eat a banana and their blood sugar goes up?
So that's one of the big reasons the sensor can be very helpful, because sometimes they're foods that you wouldn't expect. I mean, I would say, yeah, you have diabetes. It's not optimally controlled right now. Your sugar is going to rise after that carbohydrate, that banana. Yeah. It would have been worse if you had a candy bar.
Yeah. So my approach is to say, hey, if you eat a ton of bananas, your diabetes is eventually going to reverse because you're going to lose weight. So Fawn, just still on the subject of continuous glucose monitors and CGMs, sort of how do you modulate how people use this?
Yeah, well, like any tool that we have, it's not perfect. And so you have to take the information within context. So I think using the continuous glucose sensors, people can look for trends, as we talked about, their responses to other things going on in their life. They can see their responses to different types of foods. So they'll find out, I can tell somebody, hey, it's helpful if you have a little bit of a hard cheese with your fruit. But when they see the fact that their sugars don't go up as high if they have the hard cheese with the fruit versus the fruit on its own, that's much more impactful to see that response themselves. But it does take continuous education, because it is absolutely true. We have some patients that become almost a bit obsessive over it and really worry about any blood sugar excursion. And so we do need to remind people, everybody, and ourselves, it's normal to have a little bit of a glucose rise after a meal. It's the context.
Yeah. And I think we've seen many patients say, wow, if I go for a short run, my blood sugar comes down. And so I don't have to worry about that, whatever it was. Let's talk a little bit about prevention. So we've talked about there's some steps that then the conference, of course, will be going into this in detail for 5 or 6 hours. For those of you who come to the conference, that's dealing with people who already have type 2 diabetes. To what extent can we kind of predict who's going to have type 2 diabetes and do something about it before they get it?
That's a good question. You look at your family. So genetics plays a huge role with type 2 diabetes. So looking at your nuclear family members, your extended family members, if there's no type 2 diabetes in your family, assuming that everybody gets regular medical care and just isn't somebody who never goes to the doctor, your risk is lower, to the point that even if I'm seeing somebody and they have a new diagnosis of type 2 diabetes, but nobody in their family has it, I actually look for other causes, secondary causes, other hormone causes, essentially. So genetics plays a huge role. As we mentioned, weight is highly correlative. Not everybody who has type 2 diabetes is overweight, and not everybody who's overweight has type 2 diabetes, but there's a high correlation there. So particularly that midsection weight that you mentioned. It's the visceral adiposity or visceral fat, the fat that's around the organs, that's particularly metabolically dangerous. So the midsection weight is a big indicator. We look at other metabolic consequences. So on somebody's cholesterol panel, often the pattern of high triglycerides with low HDL, the HDL being the good cholesterol, the triglycerides being the fats, that pattern is sometimes related to insulin resistance. And so that can be an early sign. Polycystic ovarian syndrome, or PCOS, is a very common condition in women. And so if you have that diagnosis, then unfortunately that means you are at risk for type 2 diabetes if you don't have it already. So those are some of the main ones that come to my mind.
Hypertension, would that be another marker? So if you're an overweight person with hypertension, that you're 35 years old, it might be worth working on your weight right then, because it's likely you get type 2 diabetes when you're 50.
Sure. To help your blood pressure
or help prevent the heart attack when you're 60.
But yes, if you had a history of gestational diabetes, that does mean you're at risk for diabetes when you're not pregnant as well.
Yeah. I had a case of a lady. She came in, she's 42 years old, had a HbA1c of 10.7%, which is pretty high for an initial reading. For the listener who's not used to these numbers, normal would be less than 5.7%, and so it's a pretty high risk number. And she had 3 children with gestational diabetes in each case. And it was interesting because she's been one of our most successful. She reversed her diabetes to 5.5% and has maintained that for several years now. And it was really interesting because I would have expected her to be one of the tougher cases to reverse, and she just took the bull by the horns and got it done. So thank you for listening. We hope we've given you a little context for the idea of how to both prevent and reverse, or could lead to remission, of type 2 diabetes, and improving overall health. Because a person who reverses or leads to who achieves remission of type 2 diabetes probably has better blood pressure, better cholesterol as a result of the actions they've taken. They're going to be usually fitter than if they hadn't tried to make this approach. So it actually does more for everything, including their immune system, than simply treating their blood sugars. Although treating your blood sugars is better than not treating your blood sugars. So don't do nothing. So I hope any listeners might be interested in coming to our type 2 diabetes reversal seminar. It's on April 26th. If you're listening to this and it's beyond April 26th, well, I hope this has been helpful. And we have a book called Good Food, Great Medicine that helps some of the decision making around being healthier. Greatmed.org is our website for obviously for giving you the information as well. So even if you don't make it to the conference, and if you do make it to the conference, we're going to be talking a whole lot more about everything we talked about today and more, and including Dr. Wolf will be bringing a lot of information to us from a very practical background of having been doing this for 17 years. So thank you very, very much, Fawn, just for joining us, and let's help people get healthier.